First presenters from Wellness Rebates tonight. So thank you for coming tonight. We have a pretty huge turnout. Thank you very much to Emblem Health, our sponsor, for this beautiful facility on this beautiful evening. The structure tonight, let's get a little round of applause for Emblem, please. And our other major sponsor is Wellness Rebates, so everybody has their Get Happy pins, and you're going to hear a lot about them tonight, so we're very appreciative for their support. They provided the food and a lot of the printed materials and all that stuff. It's one of the ways that we keep our costs down is by sponsors. So anybody who grows up and becomes a really great big company, please feel free to sponsor Health 2.0. We've been part of some of the biggest healthcare innovations in New York for over 5 years. Actually with us tonight is Lori Wheeler, who is actually our original sponsor. Where's Lori Wheeler? Lori Wheeler from On-Stream Media, but at the time she was with this company called PR Newswire, which everybody's heard of, right? So they were our original sponsor when we were like 7 people sitting in a room. And that was actually before I was involved with this group. So Lori, thank you very much for all your help over the years. And tonight she's actually doing the live streaming. So right now, this is all going out over the internet, thanks to On-Stream Media. So there's actually, if you look on the Twitter feeds, which are on either side of the room, you can see that they've tweeted out how people can watch us. So pretty much from here to about where Cassandra is sitting, who's the third panelist over there, can be seen directly on the internet now. And then once we do the panel, you'll see everything. So if you're not ready to have whatever you're saying published, please don't say it, because it's going out there online. So a couple of housekeeping things. Please show respect to Emblem Health by being neat and cleaning up after yourself. Also, if you are in the back talking, please try not to talk over the speakers. Sometimes it's a problem when we do events like this. And I want to thank our other sponsors as well. Young America Capital provided the wine. Thank you, Bruce Kaufman. Bruce Kaufman back there, over there. Everybody, okay, if you guys need capital, talk to him. And I know all you guys need capital. So, well, not everybody. Also, of course, my company, MedStarter, which if you want to get capital from non-dilutive sources, i.e. customers, partners, and accredited investors soon, you'll be able to do that. Visible Bee Productions is providing videography, so if you need pictures or videos, Mike Schwartz is back there. So, okay, so without further ado, let's talk about bending the cost curve for plans, patients, and employers. And this is something that's near and dear to my heart. I created Fair Care MD a couple of years ago, and it was all about trying to get companies like Emblem sort of out of the picture. Oops, sorry. So, thank you. You got that right. So the idea that you go direct and try to fix the craziness that is healthcare pricing. I never did an event like this because, well, honestly, people talked about it a lot, but people weren't doing that much. But now you can see people are doing it, and it's insane. It's great. And actually, in honor of Emblem, they actually are bending the cost curve, but unfortunately, it doesn't always work out for everybody in the past. But I think that them sponsoring this event shows that they are looking for really great, fresh, new ideas, and a lot of other partners are too. So put your ideas out there, tell us about it. And so tonight we've got 7 amazing ideas coming out to you, and they're going to be talking about what they've done and how they're going to bend the cost curve. So the way it works is that each presenter gets a allotted amount of time, and usually 5 minutes, except for our sponsor. And then there's 5 minutes of Q&A from the panel. If you tweet it out, we'll be watching the tweets too. If you have a question, you can also raise your hand, and we'll put a mic in the middle of the room, although I tried it, it doesn't work. So, but the questions will come from the panel for 5 minutes, and then we're going to break, and then we're going to just ask the panel questions. So if you have questions for the panel, just make sure in your tweet you put in hashtag H2NYC, and then put in panel Q as your question for the panel or for the presenter. Where possible, the Twitter handles for the presenters are in your program. Also, you can get online using some of the instructions on the back of the program. So without further ado, I'd like to bring up Victor. He told me how to pronounce it before, but I'm gonna mess it up again. Edoufier. Is that right? Is that close?
All right, well, thank you all very much for coming today. Really appreciate it. Really appreciate the opportunity to share with you what we are doing at Wellness Rebates. What do I do? Okay. Can I use this?
It doesn't work.
All right, well, I'll stop.
Well, I think they can hear you. Use both.
Okay. All right. Doesn't matter how many times I give this thing. I'm always nervous. So please let me give me a minute or so to shake it all out. But I give this speech throughout the country, and we're getting really great positive response because we're advocating a new model of wellness programming and trying to adopt what other large organizations have been able to do successfully and spread that model around the country, particularly for small and mid-sized employers. So let me just get started. So I always like to talk about why we do what we do, the challenge that we're facing and that we're trying to overcome. And for us, it really comes down to the challenge on the individual level. So this chart here is called the compression of morbidity, and it compares the lifestyle of a healthy person to an unhealthy person. And for the most part, we all start off okay for the first 30, 40 years of our lives, generally healthy. You may have high blood pressure, you may have some cholesterol issues or excess or too much body fat, but you're generally okay. But then comes around midlife, you start to see a divergence. So for the unhealthy, this is the development of chronic conditions like heart disease, type 2 diabetes, and then these people start to have a negative impact on their quality of life and ultimately on the length of their life. And by suffering the negative impact that they do on their quality of life and by developing these chronic illnesses, they also start using the healthcare system a lot more. So the idea is that if we can get people to focus on their key risk factors down here, we can have an impact on the development of chronic diseases because we know what these chronic diseases are and how they're caused, and then be able to positively impact the cost curve in the United States. So why should employers care? Well, employers pay most of the healthcare costs in the United States. They feel the impact of chronic conditions and unhealthy behaviors directly through their health spending, and then they also feel it indirectly through absenteeism and presenteeism. So people who are taking more sick days off of work because of their health concerns and their health issues, people who take time off of the workday to go downstairs and engage in behaviors that are unhealthy, like smoking. These things directly impact the bottom line of organizations, and then also the concept of presenteeism and lost productivity. They're actually at work, but they're not there mentally in the game because they're worried about something related to their health or the health of somebody else. They've got stress in their lives as well. So the solution is obviously workplace wellness. It makes sense. People spend most of their time at work. They get health guidance from their employer. The employer has all these financial interests, so it makes sense that the employer should be the place. And of course, there have been studies that show ROI on wellness programs. For each dollar that you can invest in a wellness program, you can potentially save $6, half of which in medical costs and half of which in absenteeism reduction. But there was a study recently that came out and showed that that's not the case. Most wellness programs, although a lot of employers are offering what are called quote-unquote wellness programs, most of them are ineffective and they have very low participation rates, which then begs the question, if these programs are so great, then why are so many of them not working? Well, we believe that wellness has been it's been a false start. A lot of organizations, they'll do gym reimbursements, they'll have a lunch and learn, they'll have a small incentive for taking an HRA, and these programs aren't really well coordinated, they're not really well planned, there's no strategy behind them, and there's no focus on the results. You know, you do a gym reimbursement, and only people who usually go to the gym take advantage of it. You do a health risk assessment, but then if anyone shows up with a health risk, you don't follow up with it. So with this kind of scattershot piecemeal effort, we shouldn't be surprised if these programs are ineffective. So we're advocating a new solution, a new model of wellness, one that's quite comprehensive. This is a study that was done by the Massachusetts Business Roundtable recently that compared some of the top wellness programs in the state of Massachusetts. And it found that it's the programs that are the most comprehensive, that are most likely to produce a return of investment. And that's because they have high levels of participation. You're not just reaching the people who are likely to care about their health anyway, you're actually reaching more of the population. So which leads to the conclusion that it's participation that ultimately drives it. So what's Wellness 2.0? Well, we are arguing that it's strategic planning, outcomes-based incentives, a culture of wellness, technology and gamification, measurement and evaluation, and ultimately the use of behavioral economics principles in designing the program. I don't have enough time to go through all of them, so I'm going to go through some of them and then go through it as quickly as possible. Strategic planning. Healthcare expenses are the second biggest line item on most organizations' budgets, right after their salaries. They have a marketing committee, they have a finance committee, but there's no committee at the organization that's focused on helping to manage the health of the individuals that work there. So we believe that all organizations should have a wellness committee. It should be staffed with people at different levels of the organization, they should meet regularly with a formal agenda. They should gather information about the risks of the population and the culture and the interests of people with respect to wellness. And then from that information, they should set goals. Outcomes-based incentives. So this is a new model that is really advocated by the healthcare law, which ties individual premium, which allows the employer to tie premium contributions to achieving health outcomes. And the best way to think about it is in the context of HIPAA. HIPAA is the reason why all individuals pay the same regardless of whether they're the guy who goes to the gym 3 times a week or the person who doesn't take care of himself. But the healthcare law is allowing some consideration of risk, which makes, to some extent, makes insurance like pretty much every other type of insurance under the sun. If I build a house on the beach, I'm probably going to pay more in homeowners insurance. So these outcomes-based incentives tie the progress, or it ties the premium contributions to achieving or making progress towards health goals. So either you are quitting your smoking, or you're enrolled in a smoking cessation program to be able to get the reward. And that's encouraged by public policy, and these are it's a significant amount that the premiums can be associated. Finally, we believe that the culture of the organization needs to be focused on wellness as well. So we look at the values and the leadership and the work environment, make sure there's strong communication around wellness as well. Gamification, tapping into people's competitive spirit, organizing challenges like STEPS challenges, Biggest Loser challenges, that get people engaged and having fun at the workforce in a direction that impacts their health. Then constant focus on measurement and evaluation. Looking at the metrics that are directly related to health and measuring them over time and seeing how they're impacted by the wellness program and making adjustments based on that. So these are some of those factors that we focus on. And this is basically our program. So we ask the employer to set up the wellness committee, to shift the premiums based on outcomes-based incentives, provide us access to the data. Then we provide them with a full-time wellness specialist that helps them, their HR professional, manage the program, recruit for the wellness committee. We do all the fun stuff with the cultural assessments, organizing the 3 challenges a year, wellness web portal, collecting all the data, putting it in a nice digestible form for measurement and reporting to prove that the wellness program is actually having an effect. And of course, compliance with all the wellness regulations and all the non-discrimination and privacy statutes as well. With our model, we're arguing that we're offering it to the market for free. We are a licensed insurance broker, so if you make us your broker of record, we provide these services for you within that revenue stream. And also, it's a little complicated, I'm running out of time, but I'm not going to get into it. Because of the cost shifting that's allowed under the outcomes-based approach, if structured correctly, you can get extra premium contributions from non-participants in the program, and that can more than pay for our fees, biometric screenings, fitness trackers for everybody, and still have money left over for the on-site yoga or whatever else you want to do, coaching, all those kind of fun interventions. So our vision ultimately is a world where every employee knows his or her numbers, receives support and guidance on their risk factors from their employer. Ultimately, to the extent that health insurance right now is a standard employee benefit, where we want supportive, culturally focused, outcomes-based programs to be the standard of the future. We believe that the greatest employee benefit that an employer can offer is a healthy life. So that's it.
Okay, so I didn't really spend very much time talking about the panel. And what our panel here is actually an amazing group of people who represent employer, Larry Klein, in the middle, Natalie Blanc, representing a large group of doctors, an IPA or an ACO. I'm not really sure which it is, but she'll tell us about it, from Mount Auburn, also from Fit Tango. And Cassandra Harley, representing Emblem Health, a large payer. So what we are here is we're trying to pull together a bunch of thought leaders and people who've been there and done that. Eli Cammey runs Disney Special Populations. He's also done a lot of other great work and is well known in the field on the end. And of course, David, and I can't pronounce her last name either, is a vendor manager for benefits brokers. So he keeps the companies doing the right thing. So any questions for Victor for the panel? You have 5 minutes of questions. And also, if everybody else can ask questions too, but the panel gets first choice. So,
Victor, I think the incentive model, which provides support for premium, is a great idea and of value to the individual employee. But was your incentive for the change in behavior or the biological outcome?
We're advocates of the outcomes-based approach. So most of the wellness programs right now are participation-based. And we're saying that people should only get rewards for actually achieving health, maintaining their health status, or making progress. So the law says, the employer can tie the biometric results, and for those who don't achieve those results, you can come up with a lower standard for them to achieve. Maybe it's participating in a smoking cessation program, or a weight loss program, or dropping their BMI.
So that, I think what that drives often is a lag between the benefit of the intervention and the actual outcome. And so what I find in rewarding people for behavior change, if there's too much time between the change and the reward, you're going to lose their attention. So I would urge you to consider perhaps even just moving the behavior in the right direction should be incented. And then potentially, obviously, you want to get the clinical outcome. Some of that is entirely determined by biology, not necessarily behavior change. But you don't want to discourage someone who's making the effort. And as we all know, a return on smoking cessation is long ways out if you prevent cancer or even improve the pulmonary function of someone. So just smoking cessation as a behavior should be rewarded.
No, and that is what's rewarded. So the law says if the person doesn't hit the standards, so you're a smoker, the less they need to be given an opportunity to achieve the same reward by hitting an alternate standard related to that issue. So if they do complete the smoking cessation program, let's say 2 months later, they are now entitled to a reward, and it must be paid immediately retroactively as well.
Thank you.
my first time here, so I apologize, I don't get this format correct. Victor, quick question. You said your target market was small and mid-sized businesses.
Yeah.
How do you define them?
Well, small is not as small as it sounds. I think we're really targeting businesses with at least 100 employees because for many issues. One of which is obviously we're providing a lot of resources, something that you can get into, and it's got to make sense for us. But then also, there's a privacy concern. If you've got 10 employees, we're still all subject to HIPAA and all the non-discrimination statutes and privacy rules. So if you've got 10 employees and I tell you, one person here is a smoker, you've got 10% of your population is a smoker. It's not really easy to figure out, difficult to figure out who that one person is. So we're trying to use that 100 as a
So 100 to
100 to a couple thousand, because at some point,
I just wanted the number because I wanted, before I got my next question, if I may, is your revenue model is really being namely trusted the broker
Yeah.
to receive the commissions. So basically, if I understand your model, it is a trusted advisor, broker, consultant with a value add of wellness.
well, we're actually flipping that on its head. We are a wellness company that you can pay for your broker's commission.
All right, so you're taking, is a precursor to your program becoming the trusted advisor?
No, not necessarily. So we have a fee basis as well. So you can pay us by either becoming a broker, or you can pay us on a per employee per month basis.
So is the fee being added to the traditional advisory fee? So if they're, because you're in a business that, it's not like nobody has a trusted advisor.
Yeah.
I'd say 99, 98% of all employers out there have an existing trusted advisor. So you're
Yeah.
walking in there every day saying, okay, in order for you to win this piece of business, you need to unseat an existing relationship.
Sure.
Right, so that's, number one. Then you're saying, okay, well, we have this program. So I guess I'm just trying to understand is in your own ROI, your P&L of your organization, saying, okay, you have all the traditional overhead that every other trusted advisor has out there, plus you now have this program. Are you then, saying, okay, we're going to do this for a smaller margin, or are you going ahead and saying, okay, instead of 5% commission, you're now jumping it up to 7% because you need to support your program?
Yeah, this is actually one of my favorite.
That's why he's the vendor.
This is actually one of my favorite
It's a
questions.
tough question.
All right. So first of all, we believe that brokers, especially that size of market, do not do nearly enough for what they're being.
I agree 128%. However, though, especially the smaller end of that mid-market, don't need to cut you off, it's a situation where those relationships have been around since, probably the third oldest profession, and therefore you're in a situation where it's, the CEO, the CFO, his brother, cousin, these are relationships that it doesn't matter what. Again, we're in the vendor management business. So seeing it for the last 7 years of going in and saying, okay, you've identified A, B, C, D, we're not in the business of unseating existing relationships, but repairing them. But even when you find, I don't want to use the word gross negligence or anything close to it, those relationships, I have to give the trusted advisory community credit. They can teach all of us a lesson, whether it's a broker, consultants. They get an A++ in client relationship management. So they do it better than nobody else.
I agree with you. And the original idea for the company was to be primarily a broker, and then we learned those lessons, and that's why we came up with the fee basis as well. But ultimately, I do think that the broker is going to be the way to go in the future, because for a lot of reasons, MLR calculations, for instance, you can put a lot of the commissions and attribute it to wellness, so it's not part of the administrative fee. So the insurers have an incentive to work with us versus a traditional broker. And ultimately, in the long run, yes, we're going to have to unseat a relationship, and I would imagine that the bulk of our initial clients are going to, all the conversations we're having are not on the broker's commission. But if we prove what we're doing, and we prove and we produce results, And someday down the line, some corporation's gonna be like, all right, we're working with Wellness 3 Days, they're helping us control the costs of our, the healthcare costs, they're positively affecting the culture of our organization, and we're paying them X $100,000 a year, why don't you just make them our broker, and then we don't have to pay them that anymore. So that's the bet, it's a long-term bet, and we'll see who's right.
Are you currently working with any of the major insurance companies, working with them? For example, if I'm using Aetna, a lot of the major companies have started programs similar to yours.
Yeah.
But do you have any relationship with any of the insurance where you guys actually work with the insurance company so that you don't have to change anything, it just comes with, you know, if you want to buy into it and we're interested in it, you can ask Aetna to either bring you guys in or if they have their own program to supply this program.
Yeah, we're in talks with a few insurers along those lines. What we find is that they do have their own programs, but they don't have the resources to really devote to the smaller end of the market. We're trying to satisfy that need. My conversations with insurers is they'll offer wellness programs to companies with less than 3,000 employees, but you really need to be about that size to get one person that's dedicated to you to help really manage the program, really familiarize themselves with your company culture. And that's what we said.
So I always want to find out, there's one thing that in your marketing materials that struck me is that you say that you can make it so your programs don't cost the employer anything.
Yeah.
Now, do you have an example where this already happened?
Well, I can
Took your deck.
yeah, I took the slide off, but
Tell me what.
I'll give it to you, basically. So the outcomes-based model, it says that the employer can differentiate the premium contributions that employees make as an incentive for them to hit health goals, right?
I get the theory, I want to know, did it actually work?
We'll know if it works because ultimately, well, yes, it does work because there are companies that are doing this all the time. A lot. There's inevitably going to be some people who say, I don't care about, I don't care, I'm not participating in the program, I'll pay more towards my health insurance, it doesn't matter, I'd rather do that than do all this stuff. And if you do the math, they contribute more into the program, and that's more than enough to fund lunch and learns, our fees, biometric screenings for everybody, everything like that. Even if you get participation rates as high as like 80%.
Yeah, no, I love the idea. So tell me, one word, Larry, would you actually implement this for the Carlisle collection or Toronto, casuals, et cetera?
I'm going to call the human resource manager and find out if it's currently in any of the editing programs that we have. And if it's not, then I would probably ask her to check it out and see if we possibly work on it.
Right,
Right.
so, thank you. So next up, actually, while we're waiting for Rebecca to come up, hello Rebecca, your presentation is loaded. See if you can use these things. Also, another panelist has come, and one of the most interesting titles I've ever heard of, Chief Transformation Consultant, or NYPH. So I don't even know what that is, but I would love to hear more about it from Laura Gaffney. So welcome, Laura. So this is the first time in a new venue, so excuse some of the rearranging and things like that. There is a floor mic here, so if you go stand next to that mic, we'll try to get your questions in. So if you have 5 minutes, go for it.
Okay, so good evening, everybody, and thank you so much for joining us today. Thank you, Alex, for setting this up, and Anton for giving us this wonderful venue. So we are Fitango, and we provide adherence and prevention solutions. So adherence is maybe the #1 issue in healthcare today, and the current statistics about this issue are showing that over 60% of Americans do not adhere to their medical treatment. And the numbers are even higher for chronic diseases. So for diabetes, it's up to 90% of patients. For hypertension, 75%. Adherence is related to very serious issues like hospital readmissions, and this comes to a whopping $290 billion each year. So how do you solve adherence? This is a very complicated issue, and there is no one solution to it. Research is suggesting that you need to provide a combination of tools to start addressing the problem. And these are the top issues that we're looking at. Improving relationships between care providers and patients and creating a continuum of care. It's very important to provide social support to patients, and that creates social accountability. We're looking at motivation and incentives and educating patients on their health conditions. Patients who understand their conditions have better chances to adhere to treatment. Different behavioral triggers and reminders are also very helpful, and there is a need to establish a very clear action plan. So this is why we developed Fitengo, and it was a process of maybe 2 years until we got to the final product. It's a very comprehensive tool, and you can see that at the core of our solution are action plans, and those are step-by-step adherence guides. And you can see that they are surrounded by different elements such as social support, incentives, education. And the action plan is not just an adherence guide. It is also a communication tool between care providers and their patients. So through the action plan, a user, a patient, can communicate with the doctor, the nurse, and also the health plan. This is an example of an action plan in progress. Let me just close this. So this is Lorraine, and she's trying to prevent type 2 diabetes. She's getting daily instructions, tips, and she's following her weight and her walking time. Her social support system can view this information, and her care provider can also view this information. And through the feedback box on the right side, they can communicate. I'm going to skip this video because we don't have enough time. So the benefits of using Fitengo for the patients, this is an innovative and rewarding way to engage with health. It gives the patient social reinforcement, positive reinforcement, and the social support they need to stay on track so they can invite family and friends to support them. For care providers, this gives an alternative to following up with patients and remote patient monitoring technologies. It increases patient self-management and provides patient and population management tools. And this comes together to improve adherence. So connecting the dots and going back to cost savings. We know that research is showing that by 2018, remote patient monitoring technologies will save up to $36 billion annually worldwide. Adherence IT, such as Fitengo, will save up to $500 billion in healthcare spending worldwide annually. So we are Fitengo, and we want to help America get healthier. And I just want to mention that we also have solutions for employers. So I would like to get the chance to speak to any employers here and tell you more about it. Thank you.
Questions? Hi. I'm Cassandra. I'm from Emblem here. We work a lot with providers and shared risk arrangements or shared savings arrangements, and everything that they do to sort of improve care management of their patients has to be tied to their EMR. So how are you planning to work with that already installed base so that that comes back to the right people?
So we do understand that for larger care provider organizations, we need to work with the EMR, and we are talking to a few EMRs currently. And there is a very good fit with the education part of the EMR and the treatment plans, and this is where we see ourselves fit in, and we're in talks with them on how exactly technically we're going to combine it. Questions? Anybody? Yeah.
Certain disease entity that are suited for this?
So we are looking specifically to help people who are dealing with chronic diseases. And this is why we're providing a very comprehensive social support and incentives to help them stay on track, even though it's not something like a wellness solution where it's fun to really track how much you're running or how many push-ups you're doing every day. You need the social support to keep you on track.
And I'm from Amazon as well. I think depending on the population in terms of social economic strata, what we see in what we do is the social support and beyond. It's not just having a voice to listen to. It's understanding the logistics of the compliance of healthcare systems, the economic nuances. For instance, our pharmacist, the most effective way for them to improve adherence is actually just helping people lower their copays. That is the single most.
So this is something we're also looking at when we're talking about incentives, because co-pays are a great incentives when you're talking about medication and visit to doctors.
Do you have any data regarding how to motivate your patients to continually engage with your platform? That is, how many motivators they would need, or the type of motivation, or how many encounters for a specific time frame between people who fall off your platform and those who continually stay engaged?
So, like I mentioned before, it's a very complicated issue, and each patient is different than the other one, or each user is different than the other one. We do encourage or almost ask each user to invite at least one person to motivate them. It is very crucial to be in touch with your care provider. And in terms of motivation, we have different automated tools in the systems, like daily reminders and different points and badges that you're getting for just staying active on the system. So if you're logging in every day, you will get points for that. If you're tracking your health, you will get points for that. You might get a badge every time you're completing a goal. So it's a combination of different tools that work for different people. Some people don't want to share their medical information with even their family and friends, so they cannot use that part of the system, and this is why we're giving different solutions that will work for different people.
Have you had any learnings regarding the most effective features on your platform?
So we think that the social support element is the most crucial one because it creates the social accountability. So people are not just trying to improve health by themselves, but they have somebody to report to, or somebody is looking at what they're doing. So we believe this is the most important element.
Are you noticing any adoption differences in people with different socioeconomic statuses? So you have to have a computer at home to do this?
Yeah, so it's an interesting question because we're talking with a few different ACOs, and some of them are in areas where access to the internet is limited, or people are not used to technology. So it's a challenge. We do have different ways of overcoming that obstacle, and we allow to also print the action plan. So when you visit the doctor, you have the ability to select specific dates between visits, and you can print out something for them to follow. So it's not, you can get all the elements of the solution, but you still have something to follow and report on, and you can bring it back with you next time.
Rebecca, thank you for the presentation. Can you tell us how you fund the model? Is it revenue-based, subscription-based? Is it user payments? Is it
So
plan
it's very similar to how you would pay for an EMR. So a physician who's using the system, you pay per seat, and then their assistants or nurses don't pay for usage. So it's based around the care provider.
So I want to thank Rebecca for presenting and for sponsoring this event. She provided a couple of volunteers to those wonderful young ladies up front who handed you your badges and also helped set things up and receive the food today. So thank you, Fitango, for sponsoring with your staff and your time. You can always sponsor or help you out in lots of different ways. So give us a room, give us some help, for a volunteer organization. Thank you, Rebecca.
Thank you.
So next up is a good friend, Joe Bullitt. Joe coming up here. So Health 2, I don't know if you guys, how many people are first time in Health 2 tonight? First timers? Okay, wow. Okay, how many people have been with us for 3 years? 3 years? 3 years? 3 years? Okay. 4 years? Okay, the one who's been here the longest is Lori Wheeler, right over there. She was here before me. She's about 5 years. So anyway, Joe's been with us for 2.5 years, if I recall correctly. He's been working on a really cool idea. He's finally getting traction, just got out of the Health Box Accelerator out of Boston. Has all sorts of really great stuff going on. And I'm really excited. I think this is the first time we've ever presented here, and we're happy to have you. So.
Can I just use this for a mic, Alex?
Yeah.
Okay, sounds good. So, first of all, I need to thank Alex and the whole Health 2.0 organization for everything they've done over the last couple of years. For myself, personally, and our company, and I think that to a lot of companies and people in the room here today. So, it is the first time I've had a chance to get in front of the Health 2.0 audience, and there are a lot of great friends out there, and specifically want to thank you and acknowledge the help that's been provided to my company and myself personally. So thank you very much. So as Alex just mentioned, first of all, the company name is Epion Health. We just completed the Accelerator program up in Boston. It's a Health Box program. Happy to talk to anybody about the program afterwards. There are many programs going on around the country that are sponsored by Health Box. It was an outstanding program, and I can't say enough good about it. So happy to talk to you about that afterwards, and we just finished a few weeks ago. So what's Epion? First of all, just a quick definition. Epion is the goddess of soothing pain, and we're all about soothing pain in healthcare. And I'm going to talk to you today about a few things that we are attacking in the pain threshold of healthcare, and what we're doing to kind of soothe the pain. And what we're first doing is we're attacking a major pain point. It's this intake process at the point of care. I'm sure everyone hates it when you get handed a clipboard and you're filling out paper forms and everything else in the world is electronic. But for whatever reason, in the office at the point of care, it's still a paper-based environment. Over 95% of offices are still working this way. So that's the first thing we do is we digitize that process. The next thing, actually not the next, but just a comparison here. So it's a frustrating process versus a digitized process where we can do it smart. We can make the intake process through branch logic and ask the right questions, get the patient better prepared for their appointment, and provide better information to the provider. It's also linked to the patient portals and EMRs, and that's what we're working on right now. The other thing that we do is we reduce the staff time. So tonight I'm going to talk to you about how we reduce costs in healthcare. That's what tonight's topic was around. And we reduce it for the several stakeholders in the system. But the first one is the office staff. It's extremely expensive to rekey all the information in, to scan the information, to shred the documents. So we make it much less costly and more efficient. Frees the staff up to do much more valuable work loads. And what we're really after is opening the door to patient engagement. By providing this patient intake service, we now open that door to patient engagement. So the clipboard patient on the left is looking at old magazines. In the meantime, what we're doing is providing health risk assessments, wellness programs, etc., at the point of care in the waiting room in the exam room. And we go right through the exam room to the checkout where we can get patients signed up for further patient engagement programs, CRM programs, telehealth solutions, telemonitoring, anything you can imagine is going to help the patient have better outcomes and lower costs. What we're really looking at is what are the cost savings to the major stakeholders. What we look at as far as the major stakeholders is they're starting with the patient, right through the providers and the payers. And everyone in the system will benefit from wellness programs, health literacy, and efficiencies. But I'm going to break this down into cost savings by each stakeholder, and just because we have a few minutes here. It's the patients. What's effective for the patients? We can help them reduce copays by finding the least amount of copay for different ancillary services and pharmaceutical prescriptions, etc. We also help them find and use the in-network services and offer incentive programs. Like your Fantago program will be great for us to link up with, to make them aware of that, potentially sign up for it. The second stakeholder is the provider. We help them with the data entry, reducing those costs. We digitize training and education, and we can also help them collect money and have better cash flow. The last stakeholder would be the payers, and this payers could also include self-insured employers. Again, helping more patients use in-network ancillary services and providers. We also have awareness programs around health and wellness programs, and also billing accuracy, which helps the payers to get better data from the providers. Just a quick traction as far as our company is concerned. We've completed 4 pilots. We're currently integrating with Athena Health's EMR and practice management system, which will give us access to 40,000 providers. That's actually work ongoing right now. We'll be completed that early fall, and we'll launch into their system. It's an incredible opportunity for us. We also have 2 programs in place, or actually in progress at large healthcare systems in Ohio. And we have 2 other EMR integrations in the pipeline. But that's what we're doing. We're really majorly after reducing the cost of healthcare. Just imagine a platform at the point of care to provide health and awareness programs to patients, and also link that into the EMR systems so that patients are aware of cost-saving measures, and payers and providers can also benefit. Happy to answer any questions anybody might have. And again, thank you for having me here tonight. And it's just been a pleasure being part of this community.
I think it's a good idea to take advantage of the waiting time in the office. And so I also think about waiting time in the ER, where there are at-risk patients and they're hanging out for 8 hours, and they're the ones we have to reach the most. So are you doing anything with ER?
Yeah, so it's definitely our strategic plan. We have a limited bandwidth at this point, but ER and actually into the hospitals around readmissions, but ER is a perfect place. You have a lot of wait time, and also we can help with the triage for the right patients, so absolutely. Yes, sir.
One of the most frustrating things about healthcare has been you're admitted to a hospital, you have a major problem, and the hospital, of course, is under plan, it's in the plan. And then you're exposed to a number of doctors, and sometimes you're not even able to talk to these doctors. And most of the doctors are on the plan, and then some of them are not. And then when you get all finished, you start getting these ridiculous bills at the end of your stay, which, you know, can really kill you. So my question is, are you guys doing anything about stuff like to make sure that when somebody goes into a hospital, that all of the caregivers are in-plan people so that the patient doesn't get stuck with all these ridiculous out-of-plan bills?
Absolutely. It's actually, as you just identified, it's a really big problem. And one of the things that when a patient signs into our system, we know who their provider is and what plan they have. And then we can message that patients around that. And it's a really big component of what we do, helping them find in-network services and providers and ensure that they're going to the right.
I think that also, if you go for testing, and if you go to the testing in the hospital, sometimes that gets completely nuts. If you go for a test in the hospital, it's not covered the way it's covered if you go to one of the major providers.
And not only that, typically an in-hospital test is going to be more expensive than a test in an ancillary facility in the outlying areas. So we can help to direct the patient with the payer encouragement and potentially the provider encouragement. And I'll just, one last note, not last necessarily, I'm open to more questions, but we're really friendly to the ACO and shared risk environments. Because in that case, the payers and providers are on the exact same page around lower cost health, but with high quality care. So we look for those alignments, and in those alignments is where we're really targeting our service.
I'm sorry, I just didn't understand the link. You first started talking about having, like, no longer filling out all this stuff, and so you put that into your system. I didn't understand how that linked to the payer side. I missed something there. I apologize.
Okay, good question. And if you missed it, it's my fault. So I apologize. So the idea is when a patient signs in, we now know who that patient is, what their insurance plan is, and what their benefits are. So we can then communicate information based upon that information to the patient because we know who they are and what they're eligible for. So there's a link because we're integrated with the EMR system. We know who their plans, what their plan is, and we can then message the patient accordingly.
So you have access to all insurance companies' multitude of plans? That's part I'm missing. I'm sorry.
Well, so I can talk to you on it because I know I'm probably getting to the end of time here, but the basic premise here is that we're a fully integrated solution. We know the patient's electronic health record as well as what's in the practice management data from billing and insurance purposes. And we can communicate that and then we have the next link is the communication to the patient, which is a missing link in most cases.
Okay, well, talking about the missing link, thank you for.
Why the missing link?
Probably me, but, you know, that's what people tell me. So thank you, Joe. Give a round of applause for Joe. I could be wrong, but next up is Jeannie Pinder, right? David? David. Oh, excellent. So thank you, Joe, for that great presentation. I also want to ask you guys to do something. You're not going to believe it, but they can actually hear you when you speak into this mic. But they can't hear you when they're speaking out here, and they can't hear you around the room. So please repeat the question so everybody can hear it. And it's also good to repeat it back to the person so that they can understand it. So I want to talk about Larry Klein for a second, since we have a moment, I believe. So Larry Klein was my boss for 8 years, okay? Believe it or not, he put up with me for that long. And well, the reason I invited him to this panel tonight, he's never been to one of these things before, is because he is the customer here. He is the employer who has to pay for this stuff, right? I think Emblem is doing a good thing by supporting this, by looking for new wellness solutions, but ultimately it's the patient and the employer who's paying for the care that are the key voices here. So are there any other people who represent employers? I mean, I've got a company, but you know, more than 5 employees that you are a decision maker in that space. Just Larry. Okay. Interesting. So thank you for coming, and I'll let David take away the show. Thank you, David.
Thanks. Well, they're giving me 5 minutes to speak tonight, and in that 5 minutes, by the time I'm done here, employers will have lost about $19 million on missed opportunities to help improve the health of their employees. Health costs are out of control, as we all know, and 7 out of 10 CFOs rank healthcare costs as the top of the list of business problems over revenue growth, over innovation, improvement, et cetera, et cetera. So that's what I want to talk about tonight. And with those costs, 75% of them are preventable. And that's why I think almost everyone agrees that a focus on prevention, a focus on health, wellness is really critical to preventing these big costs. The problem is that it hasn't been that successful. We're seeing across the board a huge proliferation in wellness programs and disease management and all these expensive programs that employers are paying for, but results haven't been that good. So I want to get into that. Before I do, we're Health Options Worldwide. We call ourselves HOW. It's a pleasure to be here. And we are, like all the other speakers, it seems like an early stage company. We released our platform in April. We're going live with our first client in September, and we've got a few more coming online. So things have been good, and we're very excited. Talking about the wellness outcomes, for those of you that haven't been studying this too much, the ideas in theory are great, but the results haven't been so good. And we know that through participation's been terribly low, and the costs haven't gone down. They're going up about 8% a year on average for employers. And when we look at the outcomes for different programs, they're not as good as they're intended to be. Weight loss, for example, results are about a pound a year in weight loss over a 3-year period. When year 4, it starts dipping even more. Or health risk assessments, only 9% of the population actually fills out an HRA and then does one recommended activity. And that's assuming they fill it out accurately, because most don't, especially when asked to fill out 200 questions. So what we do is look at populations, and to give you a little, what most companies do is they look at the 20% of the folks that are responsible for 80% of the cost, and they target them and they try and get them in all these programs. There's no buy-in, the engagement's really not there. And we think there needs to be a big emphasis on behavioral economics to get people moving. When you dive a little deeper, all these people in the groups are a bunch of individuals. And within a population, you can't just target the really expensive folks, because some of them you can't even touch. I mean, we're talking about cancer patients, transplant patients, infertility folks, and really expensive outliers. And you've got other people that are never going to use the system ever, no matter what you do. So somewhere in the middle, you've got some folks that might use something if you can engage them appropriately. And I think very few people wake up in the morning and say, I like having diseases and I want to die younger than I should be. So the thing is it's just better to manage their health. You need a system that's easy, it's not complex, it's not intimidating, they can use, and that's what we provide. We look at costs, I'm going to run a little faster, we look at costs, that's important, but really more importantly are, what are the issues somebody has today and what are they trending to down long term from a disease standpoint? And is there a way that you can make them care about that? And that's what we do. We have about a 20-question health survey. It takes less than 5 minutes to fill out. On completion, we'll let people know what the risks are for the two biggest killers out there, heart disease and diabetes, right away. And if they care about slowing that threat of a heart attack or stroke going down, we let them know the activities they need to do. Not necessarily to eat fresh broccoli or run 5 miles, but the things a doctor would want them to do, clinical activities. You can't give them a checklist, that doesn't really work. So what we do is we wrap around behavioral economics. We've got over 3,500 behavioral messages written by behavioral psychologists, all geared towards getting people to engage to undergo an activity. This is a social norm. It's just designed to make you feel out of the norm if you're not compliant with this activity. So what we do is we take this and then we wrap it around all the programs employers have, disease managers, employee assistance programs, coaches, so on and so forth, and really drive traction into the right programs at the right time for the right reasons, all personalized automatically to the needs of the individuals. What it looks like as a snapshot is your own private portal system. This is a health management system. The tools are there for them to do what they need to do in a really simple way and get them, the goal here is to nudge them on the path of well-being and then get them there. And when you do that, that well-being culture throughout the population, that's where reductions in costs occur. That's where you can get an increase in retention, recruitment, and productivity and all that. So that's our system. We'd love to talk to anybody in more detail about it. So thank you very much.
So I remember what Health Options Worldwide was initially, right? And this is a bit of a pivot. So it's interesting. I know that won't pick up my voice. It's interesting because Health Options Worldwide started out as like a pricing service. I thought it was competitive to a company I created called ParaPRMD. And so, you know, it's interesting that now you've gone to actually get into the root of the problem, actually the behavior modifications, getting the pre-diabetic, like me, to not be diabetic, which recently is like me. So how are you going to stop me from eating that cookie? I mean, how is Health Options Worldwide going to really reduce my costs?
Sure, it's a good point, and it's funny, Alice, we've known each other for a long time, and when as the market's changed, the business models evolved too, and we still have our centers of excellence, 50 centers across the country, and really want to talk about cost reductions, as you know, it's a beautiful model for people to save money. The thing is, you can't expect people to just stop and hop on a plane and go to a really great, high-quality, low-cost institution, especially if they're diabetic or something. So you need a relationship, and that's why we evolved a little bit. Our goal isn't to get you to stop eating that cookie, and we think that's really unrealistic, and that's been a lot of the issues.
At the break, there's some really good cookies.
And that's been a problem with these wellness programs. I mean, they're really, in my opinion, asking people to just hop to the finish line without even getting to the race. It's asking that 300-pound diabetic to stop eating McDonald's and eat fresh broccoli in 5 miles, run 5 miles. It's just not realistic, and it doesn't work. Our thing is can we get you in front of your doctor for an annual physical? Can we get you in front of an endocrinologist to help monitor your diabetes or your progression towards diabetes? Have you seen the foot doctor, eye doctor in the past couple of years? Those are things we look at, getting you on the path and then nudging you to the other areas.
So you're saying you're like my wife?
Well, as I like to say, we're like the nagging mother-in-law, because I have one, so. Sir.
Going along with Alex, and I have a perfect personal example. 3 months ago, my blood sugar went way up. I've had very bad eating habits all my life, eating a lot of chocolates, a lot of candy, a lot of cake, a lot of sweets, all this stuff you're not supposed to eat. And I had a wellness coach, my wife, my parents, everybody around me kept telling me that you're not going to get away with this all your life. And it didn't take effect. And then I had this attack. I wound up in the hospital about 2 months ago. And since then, I've lost 30 pounds. I haven't touched a cookie, piece of cake, or any of that stuff, eating all vegetables. My point is that these wellness programs, I think, they're like everything else. You yourself have to come to the realization that if you want to continue living a certain lifestyle and live for a while and get to enjoy your grandchildren, etc., you need to change that. And I think these wellness programs, while I think they sound great, but I think the individuals have to buy into it, and I think that is very difficult. People that smoke, they know they're killing themselves, yet they continue to smoke. I had a truck driver at one company I worked for, he lost his wife to lung cancer. He was crying like a baby at the funeral. 5 minutes after the funeral, outside the church, he was lighting up. I was absolutely just beyond belief that he was able to do that. So, it's very, very difficult to make people behave in a way to keep themselves up. That's my point.
Yeah, and I agree with you, and remarkable weight loss and stuff, so congratulations. I agree with you in a lot of what you said, and I think smoking is a classic example. I mean, incentives don't work, right? Everyone today that smokes knows it's not good for them. So it's not that they don't understand it. They're spending, if they're smoking a pack a day, they're spending about $8,000, $9,000 a year on it, so give them $1,000 to not smoke. It has nothing to do with finances. And the thing is for our purposes, we don't have a smoking cessation program. We don't have any of those programs. But can we get you in front of a doctor? Maybe. And an analogy we have to use is the light that goes off in your car to tell you when your oil needs to be changed. There's so many things you need to do to maintain your car. A lot of us don't do it. But you bring it in every 3 months and a little bell goes off, and there's some reasons for it. We understand it. It doesn't mean your car's going to last forever. It doesn't mean you're going to be a safer driver or care about that or wear a seatbelt. It just means those little things subconsciously we understand and we're willing to do that. That's what our system's designed to do from a healthcare standpoint. Be that little change your oil light, goes off, get a flu shot, get a physical, see the podiatrist if you have diabetes, whatever. And if you're going to eat cake and stuff like that or smoke, that's not our concern. The thing is, can we help you along that path? And at some point, do you want to become a therapist? Maybe. Our thing is can we drive people to do the bare minimum of the things the doctors need them to do, not necessarily want to do.
How does your portal differ from what the payers have built into their portals?
So, we get that question a lot. I've had a little bit of experience with a couple portals. Some are really, really slick and nice looking. I think we're building a communication system. That's not, we did some really neat stuff, so it was kind of difficult, but that's not the thing. I think what's different is the focus of behavioral economics. A long-term goal of ours is to work and be embedded within the carriers and into their systems. They got these systems, we think we can drive participation, number one. Number two, a lot of people are afraid to use the carriers' portals because, it's Big Brother. They think they're going to get charged more money. They think something bad's going to happen if they're honest on the assessments.
Well, what data is feeding your portal?
So a couple things. One is, our focus is on self-insured employers, so claims data, so we can accept claims data
Where are you obtaining the data from?
From their carrier, TPAs, carriers, whomever.
Directly.
Yep, and also, we've got a 20-question health survey that we can use that data as well.
Right, but answering where you were going with, nobody wants to be honest with the portals. The payers' portals today get the automatic data feeds from the labs, so everything's showing up right in the portal.
Yeah, I mean, I wouldn't say everyone says because
No, of the 4.5 national vendors,
yeah,
their portals are being self-populated by the lab results, which is better than, even employers on an ASO basis aren't getting that level of granular claims detail. You can know they went for ABC, they have the SICD-9, the CPT-10, various things, but you're not going to get it to that level. So I'm just trying to understand, the quality of the data going.
Yeah, and the quality, that's a great point. It's really tough. We can only do the best we can. Again, we're given the data and the quality that we have, married up with someone who takes a survey. It is what it is, right? If we can get into, there's a couple companies we're gonna work with that have direct feeds from major carriers. The main thing again is, yes, it's important to do the analytics, but a lot of companies are doing it. Our thing is can you make sense of that data? Can you turn it into something actionable and get someone to do something? Can you increase flu shots, or can you increase physicals, or whatever, mammograms, whatever it is? You know, a couple of companies we've been talking with love the systems that the carriers have, but they're not loving the participation that they've been given. So, you know, some pilots we're running.
And your revenue model?
It's flexible, so per employee per month fee, $2 PPM.
So basically say that they're paying for DM and CM programs.
Depending on it, we've seen DM programs for $5, $6.
Advanced.
But also, we're trying to move away from the PDPM model, to be frank. I don't like it. I want to go more of a flat fee, maybe a percentage of savings or something. But the issue is with the PDPM, it's immediately who's not going to use it, as opposed to can we help you a partner to drive more people using it. So that's really where we're trying to structure it.
And your ROI?
You know, we're early yet to have that. We're going to go to clinical study with Rutgers University. We're anticipating looking at some numbers. We looked at about a little over 1,000 member population, and we thought when you take into inflation, right, inflation, about 4 to 7% decrease in costs.
We're gonna call the questions stop there. So thank you very much.
Thank you very much.
So now, while we're waiting for the next presentation, and this is in order, talk amongst yourselves, okay? So turn to the person. The reason why we set up these tables tonight is so that you can actually interact with people. So introduce yourself to your table mates, and we'll be back in 2 minutes.
So we're bringing transparency to the healthcare marketplace by telling people what stuff costs. You all know what this problem looks like, right? Prices vary by a factor of 10. You're completely in the dark as a consumer. You've also seen this graph, and I don't need to explain it to you. What's our solution? We're revealing cash or self-pay healthcare prices. I come from journalism. I was at the New York Times for almost 25 years. I volunteered for a buyout. So what we do is journalism. We're doing some database digging, some crowdsourcing, some partnering. These are real-life examples from our reporting. Again, this isn't a surprise to anybody here, I don't think. The fact that we found it out and we can present it like this might actually be a surprise. This is the website. We relaunched about 8 months ago. Since then, our traffic has quadrupled. What we're doing here, we have a search box at the top, and we're also showing you cash or self-pay prices for a range of common procedures. It's fairly self-explanatory. If you wanted to look at extra prices for an MRI, for example, you would click here and go to the results page, which shows you if in fact we have a connection. Not only the Medicare price, which is the closest thing in this marketplace to a fixed or benchmark price, but also the range of pricing survey prices that we have here in the New York area from $400 up to $1,200. And we have this for a range of procedures. Now, to do this, yes, we had to mess around in government data. Anybody here do government data? Anybody? We'll have a support group meeting after. We had to dig through things like this to make that Medicare price come up, but we thought it was worth the game because people actually really need to have a fixed or benchmark price to understand this marketplace. The other interesting thing that we did recently that I wanted to talk about was, as Alex mentioned, this crowdsourcing project with Brian Lehrer at WNYC. It was a whole lot of fun. They invited us to come on the show, and we talked about the project. What we decided to do was, in fact, to begin with our hand-collected 600 price points for birth control pills, which gave us this really cool little interactive map here. So if you look, for example, at the price of a common birth control pill like Trisventec, we collected several of them, but for Trisventec here in the New York area, you can use this interactive to hover over the little buttons and find out that it could be 44.32, it could be 38, it could be 50, it could be 20. Once we were done rolling out this little interactive, then Brian said, Now, dear listeners, what we want you to do, we've told you one data story, and here's another data story we'd like you to help us with. We'd like you to tell us how much you were charged for your mammogram and how much your provider paid. So we put this little form up on the website. We made everything fully shareable and embeddable, spanned the entire internet, and got back 400 responses from people who wanted to tell us what they had paid for their mammograms, what they were charged, and what their providers and what their payers paid. The blue dots here are the charge prices. The orange dots are the reimbursement rates. We had a lot of information from people who wanted to tell us how they felt about this also. We had a free-form box for people to comment. We had people who told us about how they were being screwed on their mammograms, which we truly couldn't believe. And we wrote about 7 blog posts about this, crunched some data. So that was really fun. We'll be doing more of that. Where are we now? What we've done so far over the course of the last 2 years is on the basis of $54,000 in grant funding, a little bit of friends and family money. We're hitting our stride now, just as Time Magazine, Steve Real, Bitter Pill, New York Times, $2.7 trillion colonoscopy question. We're here, we're right now. And what's new and what's next, we're now in 7 metro areas. More data, more features, traffic going up, lots of partnership offers coming our way. And we're noticing that 37% of our traffic is home, which is very interesting. You want a partner? You want to test our API? Come talk. We do have people who are standing outside the door ready to sign agreements, and we're really happy about that. And finally, why are we doing this? We're here because we think the money's being wasted, it's not being spent well. And when we run out of money, bad stuff happens. The lady in the middle lives in Arizona. Her husband suffered from cancer. He was fundamentally uninsurable. So he went on an Arizona state program, a last-ditch support for the uninsurable. The money ran out, the program was cut, and this is history. That's why we're here.
I'm sure you've seen all the work the Attorney General did in Massachusetts. And so, I mean, that's a wealth of data. So, given that that was sort of a really heavy effort they invested in Massachusetts, do you find any statistical difference in that Massachusetts data versus New York, for example?
Doesn't Massachusetts still have the highest per capita healthcare expenditures in the nation?
Right, but in terms of price and transparency, that we have the best database that I see.
You know, I'd be interested to see how that's solving the problem, I guess is the question. I mean, to have all the data, but to have it not making any effect on the problem. But in some ways, I don't know whether it's the data or what, but there's been no dent in healthcare spending.
Oh, I'm sorry, my question is, are you using it?
No, we're not right now. We're not in Massachusetts. We're a tiny, tiny startup. We started out here in New York. We're now in 2 cities in California. We're also in Texas. We're looking at targets of opportunity, places where we think we have good business reasons to go. And I don't think I'll expound on those right now, but there are things like patient groups, geographic areas. Massachusetts is not in our sights immediately, although it could be.
I actually think that the notion of making economic information available to consumers about their health care is a long time coming. In fact, it would be wonderful if portals and electronic medical records included that information as well, so that people can get a better idea of what their overall health care costs are, how they're impacted by different types of procedures. So kudos to you for making the effort.
Thank you.
So, Jeannie, I wonder, how are you going to make a difference with this? I mean, obviously exposing it is important, but so what are you going to do to bend the cost curve in reality? Are you going to let them get the deals? I mean, it doesn't work. What's your plan?
I'm going to answer your question by asking another question. This is the audience participation portion. Everybody who's uninsured or knows somebody who's uninsured, raise your hand. Okay, keep your hands up. You can raise many hands if you want to. Anybody who's on a high deductible plan or knows somebody who's on a high deductible plan, raise it. Okay. Anybody who's had, keep your hands up, everybody. Anybody who has been uninsured anytime over the past couple of years or knows somebody who has been had a gap in employment, perhaps? Okay. Questions, keep your hands up. Questions about a medical bill? Keep your hands up, everybody. Out of network, out of pocket?
Jeannie, my arms are getting tired. My legs are-
So you're my people. You're our people. And there are more and more people like that every day.
I mean, look, I've had 500,000 people come to Fair Care MD and look for a price, and thousands of them have gotten a price, and they've cut the price by half, okay, on care. And it's the same thing that Emblem does and everybody else. But the thing is that you still have that, $14,000 CT scan happening, when it should be $170 at the most, right? I got billed $1,000 for a pertussis test 2 days ago, and I paid $61 for it after all the write-downs. I mean, this is ridiculous. How is CHC going to fix that?
So what we're actually seeing in the 2 and a little bit more years is that we're seeing that there are a lot of providers who are coming forth with cash or self-pay prices. When we started out with this survey, people thought we were crazy. People told us we couldn't do it. People told us we would be arrested for asking this question, right? Alex, you were there. Okay, and now we ask, and it's just like that. People are posting prices online. Look at, it's not us. I'm not taking credit for the whole thing. There's a big ecosystem, and you're part of it.
But how does it fit in with the IPAs and the ACOs? And if you're going to do a DRG-based billing, how does that work? This is actually more a question for Natalie.
Well, if people can choose, it's constant, they can choose to identify this way, and they
So my $2,300 MRI, this was well before I was doing this. It was billed out at $2,380, reimbursed at $2,340. I had no idea because it was, $30. It was a copay, and the insurance company pays, but actually, it's not the insurance company that pays. And people are starting to understand that and to be willing to make that choice for a $400 MRI rather than a $2,300. But they have to know. They have to know.
Question from the audience?
Yeah, I think the knowledge portion is really, really valuable, but the vast majority of people do get coverage through their insurer and do have, and if the healthcare law is successful, then more people will have insurance coverage. So I think this is really valuable information, and information that at some point will add to a solution, but how is it effective when the individual is so removed from actually paying the cost? As high deductible plans increase, then more people have a direct relationship with the cost, but no one has a high deductible plan that's like, $16,000.
Oh, I have neighbors who have $20,000 high deductible plan. People who are self-insured doctors and lawyers tend to have that kind of a plan. Excuse me?
My mother does.
I do.
We're also hearing a lot from people who have, there's a big New York bank that just instituted a couple of years ago an insurance plan where all the bankers are responsible for 10 or 20% of the sticker price. So instantly they want to know, is it a $2,000 EKG or a $200 EKG? The bronze plans on the exchanges will cover 60%. 60%. So all these people who are uninsured, are they going to be out there buying platinum? I don't think so. Are they going to care about the $2,000 versus the $200? I'm betting yeah. I'm betting yeah.
Just speaking from an insurance perspective, even in the insurance coverage, you have copay, co-insurance. I think the trend is more and more towards high deductible plans, out of network, and you go to ER, you get billed out of network bills. So I do believe price transparency can be a very useful tool across population. I don't think that would be bad. It's just how, to Alex's point, is how do you pivot from how you get information to giving people the tools to actually negotiate and prices. I think that's sort of something that I would love for you guys to think
People are doing it. And like, we hear from people, the business phone is often forwarded to my cell phone. So I hear from people who are calling and saying, I need an MRI. You know, you're the MRI provider, right? And I'm like, well, no, actually, I'm not. But I hear these stories from people, like 3 or 4 times a week, from people who want to know how they can get a less expensive IUD. The price is varied by a factor of 10. I mean, that's important. It's serious money. 175 versus 1,100. You're interested and you're paying cash. You might be shopping off of this thing. You might be uninsured. Your prescription prices, again, it's, you know, not in our formulary, so you're on cash. We're hearing a lot from people who are finding that they're acquiring goods and services without invoking their insurance policy because it's cheaper to go to ShopRite, to go to Costco and buy there.
I love this conversation. I would have this conversation for years, and I have had this conversation for years. So thank you, Jeannie. I believe is Elliot, the man without a presentation. So come on up, Elliot. This time he'll actually be here. So Elliot is from Collaborative Health, but your product is Rapid Health, which we're going to hear all about. I noticed a lot of people are tweeting, so please use the hashtag H2NYC if you want your questions to show up on the outer screens here, and take it away, Elliot.
Hey folks, I want to talk about dodgeball. I want to see hands go up if you've ever played the game, or seen it played, or just watched the movie. Let's hear it. Come on, folks. Okay. I'm going to explain how dodgeball will help with the cost curve. A little bit about me. I'm founder and CEO of Collaborative Health. All we've done for the last 1.5 years is research and development in human behavior. We've been building a completely different model of personal online mobile wellness. And it's really difficult, folks. All the companies here are doing it. The challenge of engaging a large diverse audience of American adults by itself is incredibly difficult. This is what Hollywood has to do. And they get billions of dollars that goes into the movies, television, the social networking sites of Facebook and Instagram. It's very difficult because that's where our competition is when it comes to engagement. Let's talk about diet. Right? In the field of neuroplasticity, who knows that term? Let's see some more hands go up. Neuroplasticity. Very few. Really quick, neuroplasticity means that all of your experiences in your lifetime are somehow shaping your neural connections. Constantly our brain is changing. What we now learned is our emotional patterns change. So this is where dodgeball comes in. So if you were the kid in 6th grade elementary school who lost that game, got hit in the head, got hit last, these are powerful emotional experiences. Neuroscience now shows us that the more powerful an emotional experience, the stronger the encoding of the memory. What happens in my gym class when I was in 6th grade, I was a big, tall, strong kid. I could throw that ball and I hit Jack Burke in the head and I feel great. I had a powerful emotional experience that shaped an approach, a relationship to physical activity. For Jack Burke, he had a adversity experience. What you do is you track people, you see what happens over the lifetime for Jack Burke, continue to have negative experiences, shape his emotional relationship with physical activity. This is the essence of neuroplasticity. It gives us insight into how to build better systems. So one of the panelists here had a major health scare. Okay? If you study addiction recovery, you hear people say, I have hit rock bottom, or it's only if I hit rock bottom that you can change. Well, we now know what that means neurobiologically. Okay? You have to have enough pain and experiences combined with potentially enough future pleasure that it's going to bring you towards changing behavior. Because changing behavior is really reshape your brain in terms of three major parts: emotional patterns, hormonal patterns, and habits. Now, if you anybody struggle to eat well, I do still. If you don't feel full after your meals, it's very common. There are three hormones: ghrelin, leptin, and PP-Y. They control the messages that your hypothalamus sends. And your hypothalamus is going to tell you whether you're hungry or full, and any degree in between. If you've been eating the wrong foods, and you have some insulin sensitivity, your hypothalamus is going to tell you to keep eating. Keep eating. If that's your case, that's millions of Americans, you could use financial incentives as much as you want. They're not going to get poor Sally sit on the couch whose hypothalamus is just telling her to keep eating. It's not going to help them. So I applaud everybody who's trying in this space, because I know how difficult it is. There's so many different challenges. And I just want you to remember the concept of dodgeball. You can actually condition yourself. And that's what we've been doing. We've been helping people literally reshape their emotional relationships. Because if you want to do something, if you love exercise, you do it. If you hate it, it's just not going to work. So that's really all I have to say. Well, if you want to know what Rapid Health does, you come talk to me afterwards. I didn't want to give a written presentation on our product. It's an online mobile wellness service for employers. It'll be launched in about 5 months. We have major companies like Chesapeake Energy and Time Warner Cable who are all going to pilot it. It is radically different than anything you've ever seen. We bring in highly good quality videos, very good entertainment. We're going from interactive cartoons. There's a whole fascinating social structure with empowerment groups, support groups. We take the best from Alcoholics Anonymous and sponsorship programs. We really took the best we could possibly get from everywhere. Now, people talk about behavioral economics. Behavioral economics is only one small part of the behavioral model that we put together. And people talk about gamification. There's a science, and neuroscience of what makes something game-like. And it's not, I have to tell you, if you look at Anatomy, it's not points, levels, and badges that are grafted on to a system. That's not what makes a game compelling. And it was hard. We almost made that mistake and went down that road. But because we're a neuroscience company, we had the access to, like, for example, our chief of science is a full professor at Harvard Medical School in neurology, one of the leading experts on the planet in neuroplasticity. We have the director of Yale's Positive Emotion Lab, Dr. Julie Rubin. So, I didn't want to put my presentation on the company. I wanted to put it on the concepts that we need to all share that's going to help, with all of these problems. Because, if you read Eric Topol's book, The Great Destruction of Medicine, advances in genomics, proteomics, and diagnostic technologies are going to make patient care plans so much more potentially effective. That's only if people comply. Science is really challenging. So if you want to learn more about what we're doing, I'd be happy to tell you.
It just goes to show that, I've seen people come here with great ideas and, leave with the company, leave with the partners they're looking for. So, Elliot, are you looking for anything in particular? Are you looking for... Friends. Friends, okay, friends. Okay. Everybody wants to be friends with Elliot. He's over there. So, my friend, Robert Herzog, who actually owns a piece of several wineries and things like that, and the city winery as well, has been working on e-caring for a few years. He actually beat me in a contest not that long ago for his e-caring product. Really great idea, the right place, the right time. So without further ado, no, it's cool, man. It's cool. Yeah. It was just for MedStarter versus e-caring. So if you like MedStarter, you're really going to like e-caring. So take it away, Rob.
So I was great at dodgeball. I just want to say that, but in the neighborhood I grew up in Brooklyn, that meant that I regularly got beaten up by the Italian kids who were not appreciative of my taking them out of the game. I'm not sure what the neuroplasticity lesson is from that, but nonetheless, it's certainly part of my upbringing. since I'm batting cleanup here, I do want to thank Alex. He organizes these events. He's sending out the emails all the time. He runs these two companies. He's been a pillar of the New York e-health startup community for a long time. And I don't know how he does it all, but I'm very appreciative of being included, knowing him, being included in these events. So thank you.
Thanks, Bob. It's having 6 computers going at once.
I'm not sure what that was I beat you in, but I'm sorry. If you want to bend the cost curve, you need to lower costs. And we've heard a bunch of ways to do that. I think one of the best ways to lower costs is to really keep small problems in the home from becoming big problems in the hospital. And because really where do most of the major events in a patient's life occur that lead to very costly episodes for them in their home. So how do you get actionable, real-time, useful data from the home? That was the problem that eCarian has set out to solve, and I think has been successful in doing so. Because until us, there really were no comprehensive digital health records that were coming from the home. We are a tool for managing, generating cost containment procedures coming from the requirements of today's healthcare environment, capitated rates, replacing fee-for-service, and all the desire of managed care organizations, ACOs, medical homes, MAPs, et cetera. All these places are about care coordination and care management. And we have been proven successful in eliminating unnecessary hospitalizations, ER visits, MD nurse visits, use of ambulances, drugs, et cetera. And the key is to prevent the event. You don't want to have systems that simply report that something, I've fallen and I can't get up. You want to prevent the fall in the first place. Otherwise, you're not really cutting costs, you're simply giving some kind of treatment. So we have this unique interface. It's an icon-based interface that we invented, a language for it that enables home aides, patients themselves, caregivers to enter enormous amounts of information in real time about the care, the conditions, the status, the activities of a patient in their home. And that's our goal. We have a trial program we took a slice of. It's been going on since last October with dual eligible Medicaid, Medicare recipients, the most expensive big players in the system, 15% of the population, 5% of the cost for Medicaid, almost 800,000 dual eligibles in New York State alone. And we cut ER visits by almost 40%, hospital visits by over 10%, reduced MD visits, nurse visits, and the use of other costly services, and generated enormous amounts of savings for that patient population on an individual and on a population basis. How do we do it? We have this wonderful, unique interface we've developed, which enables, as I said, home aides, the patients, caregivers. This is what we use in the home, either a PC or we're using tablets in the home, and enables people to enter with the aides to say, how's the patient eating, what's their sleeping patterns, are they taking their medications, what are their vital signs, and then what we do with that information is we serve it in ways that fit within the workflow of the care manager, the care coordinator, the provider, the family member even, to say, look, you need to pay attention now to what's going on. So we have a completely configurable system both for entering information. This is where we enter vital signs, for example, because most people, cardio patients, don't have an electronic Bluetooth-enabled scale in their home, but they do have a scale. And if they have a scale, then they can use our system. Their aide can use the system. It's very visual, very easy to use at all times. Everything is customizable. So we create template care plans. For example, we're working with Beth Israel Medical Center on all the key data points for controlling CHF readmissions. We can do that for diabetes, COPD. We also have general care plans for managed care plans. We just created a sort of a version of that for another organization we're working with, Jewish Home Life Care, with Senior Health Partners to manage long-term care plan for Health First. So the idea there is to be able to generate information from the home that enables the care manager to intervene early in order to prevent the event, to keep something from happening in the first place. All of our alerts, every behavioral data point, every clinical data point, every medication-related adherence data point can be connected to an alert. So if an 82-year-old woman's blood sugar drops to 70, our normal reaction is go to the ER. With us, the aide enters that information. She doesn't have to know it's an alert. She simply enters the information. that goes to the care manager within minutes. The care manager is calling into the home, what's going on? Okay, don't panic, because usually that's an ER visit. Drink a glass of orange juice, do this, do that, and in half an hour we'll see what's going on. In half an hour, blood sugar's 106, and we've avoided a $1,500 ER visit or a $9,000 hospital readmission. So whether it's a CHF patient or whether it's all these key conditions, we enable these early interventions to prevent them from happening in the first place. We reduce the use of costly services, and we provide real-time, customizable, configurable alerts and customizable care plans for all of our clients. We also improve quality outcome measures so that patients feel more engaged, as do home aides, by the way, who love using the system instead of like playing a video game. The goal, of course, is to keep patients at home longer at lower cost and with better outcomes. Because bending the cost curve isn't about what we can do tomorrow. At eCaring, we believe it's what we can do today. Thank you very much.
Does it also give recommendations to patients what to do, or just send a provider to those in-house? Like, if the doctor said anything, can you tell the patient?
We don't play doctor. We work with the payer, we work with the home care agency, we work with the family, and they make the determination as to the response. Now, we are starting to work in a program with Pace University for working with the naturally occurring retirement community. We're looking at serving content specific, so that instead of prevention programs being generic, don't smoke, eat better, take the veggies, will be custom and tailor-made to the activities that are being entered into the system by the patient or the home aide themselves. So we plan on serving content that's specific to the condition.
And can it be related or connected to the electronic medical records?
To the
Electronic medical records, or to the offices of the...
We program out to HL7, which is the communication language for EHRs, et cetera. But right now, it's a freestanding system. People love their EHR so much, we didn't really want to get too involved with that. And again, as you've heard from other small companies here, trying to port through a legacy system could be a risk for a small company. So when we get a large enough base of users, then we'll look at that. We program to be able to do that. I should say that we're working right now with a number of pretty large agencies. We have a current pipeline of programs with patients that manage about 20, organizations that manage about 20,000 lives. That's Dog Jewish Home Services, Senior Health Care, which is the MLTC, as I said, for Health First, the Geriatric Faculty Practice at Maimonides Hospital, Beth Israel Medical Center, part of the Continuum Group, to expand the program there, Morningside House, and we just picked up some more funds recently. And then we, as Alex may have mentioned, we wanted a pilot health tech program, New York City Innovation Program, to manage with elderly frail people in a naturally occurring retirement community on the Lower East Side.
So regarding the devices, do you recommend any specific technology? Do you provide anything?
So the question is, regarding the devices, do we recommend technology or provide anything? So the answer is that we work a lot with low-income and vulnerable populations. So they don't have Wi-Fi, they don't have broadband, they don't necessarily have a PC in their home. So in that regard, we provide part of the service, at some reasonable incremental cost, but we provide a tablet, we provide connectivity, and mobile device management in order to serve that. So what we really like is basically we're getting real estate in the home. And when we've got real estate in the home, we have a very valuable commodity. I mean, our system generates, Morningside House, 800 data points per patient per month. Now we filter that down to create alerts that are very specific to the care plans of the specific patient. But that data itself for data mining is very, very useful. And then also we'll be able to serve, transportation services, meal, refilling prescriptions, et cetera, because we have eyeballs in the home where we may be the only connectivity. So we're finding a way almost to subsidize connectivity in low-income households.
Question about you using icons as the sort of interaction. Is this designed for low literacy type issues, or?
Yes, we like to say we're the bottom rung. Okay? This program is designed based initially on personal experiences of mine, frankly, from mother, but then we've seen a lot of other people going through the same thing. So home aids can be very well-meaning and really terrific, an important part of people's lives. But many of them lack English literacy skills or computer literacy. And we've trained dozens of aides in this. And the idea was to create a program that really transcended language in that regard. It's inherently multilingual. We have, as you may see, there's help text in there. We have English and Spanish versions. With PACE, we're going to be developing a Chinese version. We'll do Russian, French, and Tagalog. But the idea is that this is for people who have no computer skills and for whom English is not their first language. Anybody above that set of standards can certainly use it, but we want to make sure for home health aids that we're comprehensive in ability. We don't cherry pick any age use it.
So do you have a sense of what the learning curve is? Does it get used within a day or so after install?
Well, you know, there's an age classification. So the younger aides, I would say, they get it after training. The older one, I had a 55-year-old Hispanic-speaking woman who never used a computer, didn't know a trackpad from a mouse, and she was very apprehensive. Within an hour, she was up and running on the system and feeling pretty good about it.
Yeah, I was going to say that leads to more engagement because
Yeah,
I think their success in just using the technology.
That's exactly right. And Senior Health Partners, one of their feelings is that they're going to get better aid engagement, better longevity. You know, you spend 8 or 12 hours a day with an 84-year-old woman, that can be a lonely kind of shift. But with this, the aide enters information, and within a minute, if there's an alert going on, she's getting a care manager who's come back to her saying what's going on. So it really creates a much more comprehensive care team. When somebody goes home from the hospital, who spends the most time with them? Home aide with a family member, who has no voice at the table right now for, you know, the Canada Care Organization, the medical home, I don't care what the care coordination is. It's the patient's family and it's the aide. So we're giving a voice really to people who know the most about the patient.
Who actually pays for this? Who pays for the product?
Who pays for the product? It pays for the product. The question is who pays for the product. So with Managed long-term care plans, they get a tremendous ROI because they're under capitated, full or partial capitated rates. You know, they live or die by their ability to live under their ceilings. So the MLTC, the payer may be paying for it. An agency can be paying for it because they want to provide it as a service, a value-added service that passes up. If they're doing referrals, say, from the hospital for reducing discharges. And then we have an individual subscription program online. If you were taking care of mom today, you could go to ecaring.com and you can sign up for an individual program. So it's a variety of payments. We work on primarily a per patient per month subscription model. And then, as I said, we'll be doing data mining and providing other services to the home as part of our revenue stream.
With respect to the alerts that are generated, who's writing the business rules? Is it you, or do you work with each organization to write business rules for the alerts?
So we create this this menu of icon. We call this the icon tree. It's a complete menu. And then you can translate any element of this icon tree into an alert. So we created a template of alerts. We worked with the Chief Medical Officer at Beth Israel, Dr. David Bernard, and they gave us a set of alerts, a preset set of alerts for CHF. We just did a completely different set of alerts for Jewish Home Life because they have a general population. They want, for example, we have a category with a special problems, falls, loss of vision, consciousness. They wanted every one of those to be an alert. But if you had an Alzheimer's patient and you want to know they were combative 3 times in the last 24 hours, you could set that. So we work with the individual organizations. The system is inherently, it's completely customized. It doesn't cost me a dime to customize it. You as a client can take it and do whatever you like. You create a template for your entire patient population, and you can individualize that. So that for a hospital that has a CHF discharge, there may be a comorbidity with diabetes. If that person comes in with diabetes, the hospital's dinging the penalty box for the CHF readmission. So they may want to have the CHF panel plus, you know, information that would relate to diabetes or COPD or hypertension.
Do you also, can you send 2 alerts, one to the caregiver, or to the, to the care coordinator, but then one also to the caregiver? So that, because they have more sort of urgent interest that, mom is not eating well.
I mean, family members.
Yeah.
Yes, absolutely. The panels here are these screens it's web-based, cloud-based, so it's accessible to anybody who's part of the care team for that group, and they can be communicating with each other. We have a two-way note system that goes from the care manager into the home. So you can say, don't forget the doctor's appointment at 3, where the aide or the person in the home can say, not eating well today, I mean, hey. So that goes back and forth. But all that information is then viewable by any member of the care team simultaneously. Again, no extra cost. Web-based. Oh, sorry.
Do you have any plans for incorporating some tracking tools into the application? So, for example, if they happen to have a living scale.
The quantitative self. Okay.
Yeah, or grandma's not moving, or tracking.
The answer is that this inherently can do that. So the question is, how do you want to use the output?
Well, it would be more having an input of the data rather than making the caregiver feed the data.
Right. Well, right now patients are entering. Some of the hospital discharges, the patient does a PC in their home and is self-entering data. I'm not sure an answer to the question.
Well, something like having a Fitbit or something.
Well, we can integrate, if somebody had a telemonitoring system at home and wanted to integrate the data from that, then we could do that. But our feeling is, 99% of people go home with a CHF discharge or have been diagnosed with arthritis, don't have a YouTube, a Bluetooth enabled scale. So,
Okay.
Thank you very much.
So thank you. We're going to be bringing out some cookies in a moment, and then we're going to have a panel, so a little sweet and then more sweet. I want to thank OnStream Media, which people who are watching right now online. Lori, do we have a lot of people watching, or no,
Me.
not a lot? Okay. But sorry about the Twitter feed being messed up. I didn't realize that it was not putting new ones up. But a lot of you have been tweeting, and I'm sorry for chastising you for not tweeting. Anyway, so enjoy the cookies. We'll be back in 5 minutes, maybe 10. Without further ado, the panel going. So, Dr. Natalie, I can't pronounce it, Natalie. Why don't you tell us a little bit about you and what you do?
So, hi everybody. I'm a primary care physician and a hospitalist at Mount Auburn in Cambridge, Massachusetts. I'm one of the medical directors at the IPA there. And our IPA became an ACO about 2 years ago. And as ICOs, the ACO model is shifting away from the fee-for-service model where we are held more accountable for the quality of care that we give and for the medical expenses. Our ACO tries to reduce the medical expenses in different ways, but mostly at this moment is by increasing the infrastructure of the outpatient with more social workers, more case managers, reducing admissions and readmissions, and more coordination between the inpatient and the outpatient care. In addition, I'm a Chief Medical Officer at Fitango, that you saw in Efra's presentation. Fitango by itself can also actually reduce a lot of the costs by increasing adherence and more coordination of care. And currently, I'm leading the project at the Primary Care Center at the Harvard Medical School of End of Life. And what I do is I try to spread a conversation about end of life with patients and their family members. The idea is to try to educate them more about what the options and the choices that they have, that they will be able to make better decisions for themselves. But this also influences the costs, since most of them actually do decide to do less towards the end. And as we all know, the bigger chunk of medical expenses these days are in the last month of life. So those are all the ways that we're trying to reduce costs. And I'm happy to take questions if you have.
Okay, so let's hear 2 minutes about you, Cassandra.
I'm Cassandra Early. I'm the Director of ACO Initiatives and Shared Savings Programs for Emblem Health. So we work with organizations that are ACOs, and we partner with them to provide them with data and coaching in population health management. I work with Dr. Ames, who's a partner who leads this program with me.
I'm Larry Klein, CFO for a apparel company, Carlisle. Been there for 16 years, and the reason I'm here tonight is because one of my biggest jobs has been controlling medical costs for my company. The company was very, very profitable at one point, had a lot of money, and then in 10 years went into bankruptcy. So through those 10 years, my biggest expense that I had to keep reducing was our medical costs. So I was interested in attending this and hearing some of the new ideas on how to control medical costs better. That's why
I'm David Nykrug, CEO of Optimatum Group, which is a vendor management firm for the HR supply chain. Through our employer-sponsored healthcare group, we work with employers to hold their vendors accountable for what they signed up to do, which is control healthcare costs. We focus on improving the relationships between the employers and their vendors for better outcomes between all parties.
Hi, everybody. I'm Eli Kemai. I'm the Executive Director of Vaness New York Choice Select Health. Select Health is an HIV special needs plan. It's a fully capitated Medicaid plan for adults and children living in New York City with HIV. We have, of course, the same interest as we have heard among the presenters around improving adherence and making sure that our members are as healthy as possible. We have adopted technology in various ways, including patient portals, and we are about to do some pilot project around text messaging or reminder alerts on refills of medications and specialty appointments. We adopt and have been very interested in the work of Ron Berwick around the AAA, which basically suggests that you work on controlling per capita cost, you improve the health of the population you serve, and you improve the care experience. And you do those three things to achieve the outcome that you are looking for. What we don't want to do is just cost shift. Obviously, with HIV, medications are the single most important intervention we have, and making sure all our members who are HIV positive, the children don't necessarily have to be positive, but the adults who are ought to be on the treatment, and in doing so, we can control hospitalizations and other illnesses. However, that being said, people with HIV now are living much longer and at risk for other illnesses, including heart disease, cancer, diabetes, and in particular now hepatitis C is becoming a big issue. So our goal is to actually treat as early as we can and prevent more acute illness. Thank you.
I'm Laura Gaffney, and I'm a consultant to New York Presbyterian Hospital in their transformation efforts. And this really started about 2.5 years ago when healthcare reform was being passed. And the New York City hospitals, rightfully so, took a look at their economics and saying, what is going to be the impact of healthcare reform on the health of the financial health of the institutions? And in New York in general, although more people may be insured, it's not a very large number because we are a very generous state in the first place. So the real impact from a hospital perspective is loss of revenue over the 10-year implementation timeline. And if you're Presbyterian, those numbers are pretty staggering, and in terms of losses, potential losses. And so they kicked off this initiative in a proactive or forethought way, a forward-thinking way, to say, we better start bending the cost curve here at New York Presbyterian. And I have been very impressed with the organization. So I've been there a little over 2 years, and there are so many initiatives. Over 2.5 years I've been there, we've had almost 400 initiatives going on to bend the cost curve, and they're everything from trying to decrease variation in cost of care for given types of patient populations, whether it's pneumonia or COPD, that type of thing, to actually really taking a look at how the hospital staffs specific laboratories, nursing units, and that type of thing. They have programs that are focused on the outpatient continuum care and how to manage with care coordination, the outside how to manage decreasing readmission rates and all that type of thing. So it's a very, very extensive commitment. In the last year and a half, or last year, we've taken about $90 million of costs out of Northwestern with the goal to continue that progress into the future with the goal of about $60 million a year to continue to bring costs down.
So thank you. So I guess the one thing we all came here for, and what attracted me to this idea is what's actually bending the cost curve. So Laura, you're talking about some pretty interesting data there. I think let's just go down the line, starting with Laura, and just tell me what has been the #1 impact in your experience so far. Maybe it's something you saw tonight, maybe it's something you did this year. I want to hear about the data though. What can you tell me?
If you look at at New York Presbyterian's 90 million so far, the biggest #1 thing, and the biggest financial impact is reducing length of stay in the hospital. So, dollar for dollar, if the patient can stay less time in the hospital, we are going to save money. We do a lot of work around pathway development, changing antibiotics, changing the number of lab tests that gets done. Those are sort of the haircut weekly done.
I'm going to interrupt you and just say one word, Millimap.
I'm sorry?
Millimap. Remember the maternal Animat in the hospital in 2 days? It sounds like that. How is this different?
It isn't different. If you look at the United States, we're probably hovering around the length stay of 5 days. So it's very, very tough to keep bringing that down. And I think I've done some international work recently. Some other countries are doing 14 days or 30 days. So we're doing extremely well as a country. And I think some of the bigger initiatives around length of stay are more some of the preventative things that we talked about today. Preparing the patient before they come out of life with things, or trying to keep out of hospital in the first place, trying to manage both your hypertension, same kind of managing diabetes, some of these things that are more difficult and more challenging now to get even lower than 5 days.
So it's more of a community effort. I mean, you have to keep the community healthy. You have to keep them out and get them out. So, Eli, you've been working with specialized populations for decades. I'm not saying that to say you can, never mind, I'll stop right there. But anyway, so you have a lot of experience in this area. Tell me what works.
Well, what we find is that care coordination is the major function of making sure that people who are engaged in care are actually getting the care that you provide. And it's not just about medical care. It's about being able to make sure they have transportation. It may be about stable housing. It may be about meeting needs around their food, whether they have enough food in home. People prioritize how they spend their time. What we've been fortunate to have in New York, which I think is something we're still trying to determine as being the right strategy, is New York State decided to take on a concept called the Health Homes, which is a reimbursement model for the first time for care coordination, not case management, although it includes some of that, but a reimbursement rate based on the acuity of the patient. And so in our plan, we have members who are eligible for a care coordination intervention that can range anywhere from, I think it's about $200 to $300 to $400 per member per month. This is outside of the coverage we provide for their medical care. The care coordinator knows the patient, knows the different aspects of their care, and knows the provider network that that patient is in. What we find is oftentimes one provider doesn't know what the other provider is doing, and the patients themselves may not know the system that they're in well enough to know how to get the care that they need. A care coordinator can make that happen. And so if you want to make sure that a patient who's been diagnosed with some sort of treatment, let's say heart disease, is getting to a cardiologist, the plan can support that reimbursement for the visit, but how do you get the patient to the cardiologist? And that's when you reach out to have the care coordination to make sure that there's a collaborative effort to get that done. New York has done this. We don't know yet whether the results are going to be as outstanding as the cost and the reductions in savings, but we're very optimistic optimistic, this is the way you can improve the way you build care delivery systems. Most providers don't get reimbursed for doing any care coordination. They only get reimbursed for a visit. And that concept is a very limiting concept for the healthcare delivery system and for the patient. Being able to reimburse for the interaction between visits and actually to be able to engage patients and providers in that process is, I think, what will make a difference.
So now, from the perspective of visiting, that's both the care provider and coordinator and as an insurance plan, are you saying that only in that scenario, and is it that where you can actually successfully control the cost because it's not reimbursed typically, but you guys see the cost savings because you're reducing?
Well, I think the way the state is approaching this is they're seizing a model with funding that the federal government has supported. But I think over time, it's going to be added to the capitation rate of plans because who wins on cost savings? The plan does, right? So theoretically, the plan should be able to fund its own care coordination model through the savings achieved by reduced hospitalizations. Now, that only works if the state doesn't bring down my capitation rate. So it's a shared saving approach. We'll see how far we get with it.
It's also very regulation-based, and we all remember, some of us remember the PPS system for LTCs, back in the 80s. And that was wonderful. It was elastic, but when it went away. So, something has to be sustainable, I think. And I think it's there. So, David, you kind of sit on sort of the outside of this. You see, from hundreds of ideas being tried from hundreds of companies. What's the single best approach here?
Well, how much time do I have?
You've got 16 seconds.
I don't need to burst your bubble. There isn't a silver bullet. If there was, I hope I would have found it and I wouldn't be here. I'd be on my favorite island. That being said, and I'm sorry to everybody, excuse me, how many people are here with a new idea and a new business, a new concept? Show of hands. I hate to break this to you. We actually have all the tools necessary to control healthcare costs out there. The vendors actually all do a good job with delivering those services and those solutions.
Why are costs higher here than everywhere?
The challenge is they're doing a good job. In any model where you have hundreds of millions and billions of data points on a daily basis going through the system, there's always room for inefficiencies. And the challenge is on the vendor side, and for the vendors for a moment, they go to, let's just talk about it from the traditional world where half the United States, where they're getting health care from their employer. Vendors go to employers, says, we're going to do a great job controlling your health care costs. Okay, that's number one. The challenge is they're all afraid to say to the employer, for us to control your health care costs, you have to do A, B, C, D. You have to have incentives, you have to do this, you have to do that. That's number one. Number two, from the vendor standpoint, again, they're doing a good job, but there's room between doing a good job and a great job. As an example, there's a vendor out there that a year and a half ago, they replaced the outbound call model on case management from a human being to an automated system. Right? And looking at that, and it's like, guys, and by the way, they didn't change the pricing model, so employers are a little perturbed. But that being said, we have everything we need. It's talking about improved efficiencies. Today in the office, we're looking at, I want to say, $70 million over 2 years in healthcare spend for one of our clients. We found within that, I want to say $1.2 million in charges that they were actually paid more than they were billed. Is there an excuse for that? All technology should be perfect. Why do we run a 3% mismatched copay rate at pharmacies? How many people ever thought about that? There are a lot of little things that add up. How many vendors, you talk about all the people that we see, that you see, that say, hey, we're going to save the company 5%, 10%, 15% on a single solution. There's no single solution that could, it is all these solutions bundled together that deliver a cost containment to employers and to the market.
Okay, so that was way more than 16 seconds. But,
I apologize, take it out.
And I mostly wholeheartedly disagree with you, but I'm going to leave that for later. Mr. Klein, so when I joined the Carlisle collection back in 2001, we paid about $7, I think, a person. That was for our, lower co-paid employees per week, I think, for insurance, and we had like $20 co-pays and such. And when I left there, before they went into bankruptcy, a year or two after, people were paying like $400 or $800 a month for their out-of-pocket. These are people who are earning like on average $11 an hour. I know because they all used to work for me. And they weren't happy anymore. They were opting out. I think they actually were using the GHI network. So I guess my question is, what have you seen that actually works from the employee's perspective and from the employer's perspective?
Well, unfortunately, when you look at containing medical insurance costs, a lot of times what the company is saving is coming out of the employee's skins, just like you mentioned. When the company was doing very well, there was no need to charge. We were a very nice company to our employees, and therefore we had a very rich plan from one of the best providers, United Healthcare, and we paid practically for all of it. We paid for 90% of the medical costs, which in those days were unmatched anywhere else in the private industry, as far as I know. And what that did is, number one, when you do that, and that included family coverage as well. So what happens when a company does that is that everybody brings their spouse on your plan because you're giving out this great insurance at very low cost. The spouse works for a normal company that's charging much more for her care. She doesn't even go on her own insurance, she comes on our insurance, and so therefore you're exposing yourself to all this additional liability because everybody's going to come on your plan. So to contain that, we immediately had to, as things started going downhill, we had to keep increasing the deductibles, made the family plan very expensive, which removed 60% of the population that was taking the family plan. 60% left immediately once we raised the family plan to where it should have been. So and a lot of those people also had double coverage. So there's a lot of abuse that goes on with employees. They don't, as long as, like somebody was mentioned it earlier, employees don't see what it costs the company for medical insurance. As long as it's not coming out of their own pocket, they don't care. So people take double coverage. My wife has coverage with her company, but once in a blue moon she may get an extra $20 by going on my plan too. And if it doesn't cost us too much money, she's going to go on there and have double coverage. In the meantime, it's costing the company a fortune to have this family coverage, which pays very little because most of the time it's not even used. So I'm talking too long and too much, but basically what it comes down to is that the company had to keep reducing our insurance. We went from the best insurance company to the worst insurance company, and our co-pay from our employees went from practically nothing to a ridiculously high figure. And in the meantime, we kept playing around with the coverages, reducing coverages, and not covering certain drugs, and we had to do all kinds of
So Larry, I know I have a long history of interrupting you, so I can do this. Yeah, I've thrown him out of meetings in the past, right? Remember that first meeting? That was great. Anyway, so my real question is, though, what works? What's worked now?
What works is
Which does nothing work yet.
Nothing works, but what works better for my experience is, number one, I believe that self-insurance is much better than going with an insurance company. When you're self-insured, out of the 16 years that I'm in this company, we're self-insured about 12 out of 16 years. And for most of those years, we were able to contain everybody else. I ran a CFO group for many years. I had about 30 people on that group. And one of our leading topics at our meetings was the cost of medical insurance. And my company was one of the few that did not go up 15-20% every year. When we were on self-insurance for 8 out of 10 years, we were able to contain. We had practically no increases in our insurance. We were lucky, not that many people got sick. So I believe in self-insurance. I believe self-insurance is a better way to go if you're a certain size.
What size companies?
We had 250, 300 people in the plan, so a lot of people tell you it's too small, but we didn't find that to be the case.
But there are many, many more. The vast majority is smaller than, so it's the model.
Yeah, so, no, I'm saying, he's asking me about our situation, I'm saying for us, that was, so if you're a certain size, I think self-insurance was better.
It's bending a cost curve for a company, but as far as bending the cost curve as a policy.
And then I think what worked for us is designing the plan in such a way to make sure that the employees stay in the plan. They only go to doctors that are in the plan, they don't go out of the plan. If they go out of the plan, it costs a lot of extra money because if they go out of the plan, they don't get the discounts that we can get from the people that are in the plan, that ultimately costs the company a lot more. So you have to make it a lot more expensive. So we went from having 70% of the claim in plan to 92%, which helped us to contain costs. So I think there's a
So, yeah, cost awareness by the consumer, which is what?
No, and making the employee feel the difference that if you go out of the plan, you're gonna pay a lot out of pocket, whereas if you go into the plan, you pay a little out of pocket. So now they're feeling in their own pocket, they're gonna change their behavior. And even my wife always works for doctors that are in the plan.
What I've seen some other companies starting to do is they're actually giving their employees the pedometers and saying, your plan costs will go down. And, there's plans that accommodate this and facilitate this, so.
And then the third thing I think that's been good for us is we have different classes of drugs, and if you take certain very expensive drugs, if there's a generic version of that drug, to make sure that if you want to take a very expensive drug, take it, but it's going to cost you a lot out of pocket. So it's a completely different coverage for the Lipitor and for the generic version of that drug.
Right, so your own version of formulators. So Larry is probably the best boss I've ever had, including being my own boss. So let's move along. Cassandra, why don't you tell me a little bit about what you're doing and what do you think works?
So what we're seeing, working, we've also selected the providers that we're working with because they're motivated to take on more accountability. They're more like, your organization or, a Presbyterian who sees the light. So we selected partners like that who are moving towards patients that are in medical home or are participating in Medicare ACO. But they still have opportunity to roll out these models. And so what we're seeing are some of the tried and true methods or interventions that are just actually being implemented now at these providers. So, identifying their high-risk members and making sure they're connected with their PCP, identifying patients with multiple admissions, making sure they're have a good care plan or are connected with their PCP, identifying ER frequent flyers and getting them back to their PCP, and supporting that with financial incentives, so they can get paid for it, as was indicated. So, I think that's what we're seeing is really stratifying these patients and getting them more connected with a medical home, someone who's going to know them, building that relationship with the physician, and then as a plan, trying to figure out where the services that we can provide, like other disease management, where we can plug that in to support these providers. But right now, all the costs that's coming out of these providers, total medical expenses, admissions, ER visits,
It must be you.
So actually, I agree with all those ways to try to reduce costs by shortening the stay and coordination. And I think that the main thing that we see at this moment is The moment a patient is followed immediately after discharge within a week, not more than 10 days with a primary care physician, then we definitely reduce the amount and the rate of admissions, which is a huge thing actually. Within 30 days, not just the penalty of Medicare at this moment, but also really like the length of stay becomes even more longer with the complications. So this tweak of having a quick follow-up made a lot of change to us.
Okay, so I'll ask a question myself. I run Fair Care MD as well, which is online price negotiation for prices. So what we find reduces the care is actually finding doctors who will charge you less. That's a crazy idea, I know. So like in New York, you can get like an MRI for like $399 or an ACL replacement for, $2,700. If you go to the right place, if you go to the hospital, it costs like $6,000. So, so we found that you can reduce costs by about 46% on average. If you go and actually ask, 17 places for a price. Is it easy to do? No, we do it for people all the time. But if you're not afraid to have somebody, treat you like dirt for asking for a price, it's not a big deal. So this is a service we offer for free. But now actually it only takes about 2 calls. It used to take 17 calls. But now you can call the right place, you get a price pretty reasonably, and you'll save a lot. So that's just, my simple solution. I'm a simple person, come up with simple answers. So anyway, so now actually I'd like to take questions from the crowd. So I see Shamil Goldberg has a question. So Aman, why don't you bring Shamil, Mike? And direct your question if you can to a particular panelist, not me.
Quick question for the managed care plans. If you see such price discrepancy, how do you sit down with negotiations? Because I think NYU had $1,200 for an MRI versus $60. How do you let them get away with that?
We don't base our reimbursement on the charges at all.
But they have leverage on the negotiations, so they're able to get, from their perspective, they're saying it's their cost versus the diagnostic place down the road that their costs are much lower. So out of pocket is costing more the patient, so cost of care.
Yeah, I mean, we don't use charges at all. So I can look at this from 2 different perspectives. I used to set prices at a hospital in a previous life. And sure, you do use costs sometimes. You use a lot of contract logic as well. It's kind of almost a self-feeding. You use, your Medicare cost to charge ratio. You use a lot of different things. But we don't use that. We use volume. We use things we know about costs in the community. We don't use charges.
Any other questions?
I just want to make a statement. I have a revolutionary idea while I'm listening to this. I think we should all speak to our politicians, to our congressmen. I think one of the ways to solve the medical cost problem in this country is to put in laws that say that, for example, a smoker, if you want to kill yourself, that's great. That's your decision. We live in a free country. However, in terms of medical care, since as a smoker, you're going to cost the company a lot more money than a non-smoker. Therefore, a company has the right to, right now, if as a company, if I'm going to charge a smoker more than a non-smoker, I'm guilty of discrimination. I personally think that is not discrimination at all. I think if you're stupid enough, of course I never smoked in my life, so it's easy for me to say. However, I believe that people that abuse their bodies and do things that are harmful and cost the companies tremendous amount of additional medical costs, the companies should have the right to charge those people more than they charge the regular.
So Larry, I'm happy to report that actually that is part of what's coming down the pipe now, and it's and more plans are incorporating feedback loops into your behavioral patterns. And it can change.
It's going to be legal, because I thought that was discrimination.
There's basically, if you will, or somebody probably can explain it better than I can. But a lot of plans have been producing patient-centered medical homes, right? and different types of feedback loops where you are accountable for your care.
Right.
Not only you give, but as the patient, you're signing away that your premium could go up or down 12% based on certain metrics. And it won't necessarily be smoking, but it will be things like
It could be a weight, it could be, and also I think you can see that at least if you use an intervention, if you go into, if you try to stop smoking, different, just,
So are there other questions?
Yes. I had a question specifically for Laura. In a way, we're all here to try to transform healthcare. And I was just curious, as someone who has transformation in her title and who works for a big healthcare system, you're trying to change things, and change is often not well received. And I was just curious as what the reception was to the things that you were trying at NYP.
Oh, not well received would be good. Yeah, I think that's probably the hardest part. No one wants to do things they don't want to do. It's easier to do the status quo than to move in a different direction. There's no doubt. And so, having thick skin and using lots of good data. I think data to me is your best friend when it comes to kind of promote change. And there has to be somebody at the top that wants to participate in this, bending the cost curve to make something happen at all. So some level of motivation, some level of data, and a lot of thick skin. And creativity. I think a lot of what we're talking about here is creativity. Like that's what this whole room is about. It's a lot of creative people who are all trying to come at this with different angles. And some things fix, solve some tools. So yeah, no, actually that does make sense. We could maybe try that, but it's not an easy business to not for the faint of heart.
Thank you.
All right, question this way.
Question for Cassandra.
Can you introduce yourself?
Hi, I'm Murray from Talk About Health, Patient Education, support website. Question is, you guys were talking about socioeconomic status earlier and how that relates to different forms of connection and education, et cetera. How are you guys taking into account socioeconomic, people in different socioeconomic groups, how you're managing your ACOs?
We're trying to take that into consideration. Emblem is mostly Medicare and Medicaid insurance plan. So, most of the populations we're working with are elderly or low income. And so, we do a lot of different things as a health plan to sort of understand the needs of the population. And then we also have done some things in terms of reaching out to those communities. We've opened these neighborhood care centers. We try to wrap that data in some way back to the primary care so that they know about mental health conditions, or they know about, or that they even ask questions. They should be asking their own patients about those questions and their needs. In some cases, we can, in very high-risk patients, we can go into the home and identify some needs that we can, a social worker can help them with to address those.
I think in New York, just like many urban centers, if you do hotspotting, you're going to see disparities even within micro neighborhoods. So if we look at our colonoscopy screening rates, we know exactly geographically where the disparities are, and you bump it against the census, and you get your social demographics kind of. It's not 100% match, but you know where the disparities are. So I think geography help us a little bit. I mean, if we look at our ER utilization rates, the highest rates are, again, in neighborhoods where there tend to be more of a diversity of population and across socioeconomics. One thing I haven't really heard today, which I think I'm personally becoming more and more interested, is the whole notion around patient segmentation. There's a whole kind of discipline around patient engagement, but how do you engage them? How do you identify high-risk members? And the traditional clinical model of looking at, diagnosis and weights and the biometrics and demographics is great, but there's another dimension. And there was a great article in Health Affairs, I think in June, that talked about patient segmentation at the patient-centered medical home level because your care management resources is limited. So maybe in a very, managed long-term care plan, everyone's sick, but we have 3 million members, and I only have 25 nurses to make phone calls. So who do you make phone calls to? I think those are the hard questions that we need to kind of dig deeper. And even with patient-centered medical home, you can't have high touch on every single patient that comes through the door. So who do you really deploy your care managers and your care coordinators? So I really think a lot more work needs to be done around patient demographics and segmentation, and not just demographics, it's their behavior, their history, so a lot of other stuff that goes on. Just
How they like to be communicated with.
We've done some work here at Emblem too about how they like to be communicated with, just in terms of what will they play in their family. And so, if you're going to set out patient education materials, not everyone likes to be communicated or considers the same things that is important.
It's a definitely an interesting conversation, and I wish it could go on all night, but it is getting kind of late. So, are there a few more questions? Sanjeev Lam.
For the lady with Emblem Health. In terms of managing that high-risk, high-cost patient, are you guys trying to do anything encouraging your provider networks or healthcare systems to take on greater risk, trying to encourage them to go down the road of an ACO or something in that spectrum? And are you having success?
Yeah, that's my full job.
Oh.
Is to
So it must be successful.
find those providers, find out where they are now, and so what incentives can we put in place to mature them so that they can take on more and more responsibility.
Is their biggest reason to not do it is that they're afraid to take that kind of risk? Financial risk?
Depends, I think, on their own business strategy. Some groups are much more motivated to move towards sort of the newer models. They see it as an alignment of their business model with their values. So you see, a faster migration, but in some, some providers have told us very point blank that they don't want to participate in those kind of models, that they think they have an advantage in the fee-for-service model, and they're going to stick with it. So it depends on their own business strategy, sometimes geography as well.
So, it gets into the whole issue of how could they conceivably manage costs without sort of systems and risk management and actuaries and things like that. So it's a challenging question for any physician group. I know back in the day when I was negotiating for physician groups and capitated, contracts, back in the 90s, it was really hard to do the math on that. So, more questions? Okay, so we actually have, so first of all, I look at the big picture and on. Panel, do you have any questions for each other or the crowd? I think Eli has one. Okay, so thank you everyone for coming. Thank you to our panel. Thank you to Emblem Health and Wellness Rebates and everyone else who supported. Thank you to our team, especially Donna Cusano, who helped arrange everything and did presentations and things like that. Thank you to all of you for coming today. There is a F down the street, a place called the Francis Tavern. It's at 54 Pearl Street. So if you go out the door and go left, I think. Thanks.